Hello everyone, it's Dr. Locklear here, and I'm coming to you with the concept of perfusion. So when we think about perfusion, of course, we're thinking about the circulatory system, oxygenation in the blood, carrying to the vital organs and all of the parts of the body. We are looking in this recording at Exemplar 16C, and our focus is going to be coronary artery disease with a focus on angina. Now, this chapter does talk a lot about acute myocardial infection and acute coronary syndrome. That will be covered in NUR 211, so I will be skipping those sections. So make sure you follow along clearly as I go through this. This is going to be kind of a lengthy recording, so just bear with me. Cholesterol is good for you. It clogs your veins so you don't bleed as much when you get cut. Cholesterol sure makes our food taste better. That's for sure. Here are your learning outcomes. Again, we're going to look at the patho of CAD, what causes coronary artery disease, our risk factors, and our modifiable risk factors versus non-modifiable, things we can and can't change. Clinical manifestations, what will you see when you assess a patient? What presenting symptoms will they have? There's multiple diagnostic tests to use for diagnosing CAD. How do you differentiate care across the lifespan? And you do see CAD more in the older adult, but younger people do have it depending on other underlying conditions. And how do we apply the nursing process? So how do we assess and implement and those kinds of things? So our overview. Coronary artery disease is a leading cause of death for males and females in the United States, and it gives you the numbers here of how many people. Coronary artery disease is caused by impaired blood flow to the myocardium, which is the muscle around the heart, usually due to accumulation of atherosclerotic plaque in the coronary artery. So in other words, as you see in the picture here, you got plaque built up in the vessel, and when it occludes the vessel, it cuts off the blood supply, and you're going to have decreased blood flow or no blood flow, and you will have ischemia, which is pain. And in the picture here, this person is having an acute MI, and I will mention that briefly. One thing about acute MI, and again, it falls under coronary artery disease, is rapid treatment. And I want you to remember this. And some of the most quick things we need to do, of course, is start CPR. You want to give the patient an aspirin, put it under their tongue and let them dissolve, and get ready to call EMS. And the patient with the AMI, and again, you're going to get this in another course, but just to give you a little overview, when the blood supply is cut off to the heart, you are going to have severe chest pain. Patient will grab their chest, and they may have pain in their jaw, and their shoulder, and their chest, and their back. They're sweating. Sometimes they may just say they don't feel good, or they got epigastric pain. Another medication, and I do want you to remember this, is nitroglycerin. You can, most people that have angina keep nitroglycerin with them, and you can take a nitroglycerin when you have an MI as well. So I will be mentioning MI briefly throughout this, but not going into great detail. But I do want you to know that aspirin and nitroglycerin are two of the medications that we use. CAD may be asymptomatic, so no symptoms, or it may lead to angina pectoris, acute coronary syndrome, acute MI, which is a heart attack, dysrhythmias, heart failure, and even sudden death. Angina pectoris, and that is our focus in this chapter, or angina, is chest pain resulting from reduced coronary blood flow, which causes a temporary imbalance between myocardial blood supply and demand. The imbalance may be caused by coronary artery disease, atherosclerosis, or vessel constriction that impairs the myocardial blood supply. Hypermetabolic conditions such as exercise, thyrotoxicosis, which is a thyroid crisis, stimulant abuse, so from drugs, illicit street drugs, hyperthyroidism, because it causes your heart rate to race, and emotional stress can also increase myocardial oxygen demand and precipitate angina. Other conditions that affect blood and oxygen supplies and trigger angina include anemia, because you don't have enough hemoglobin in the blood to carry the oxygen, so it's starving of oxygen, heart failure, ventricular hypertrophy, and pulmonary diseases. And so some of these diseases are acute coronary syndrome, or ACS. It's defined as sudden reduced blood flow through the coronary artery, so these are the arteries, not the veins, thereby resulting in reduced delivery of oxygen to the cardiac tissue. This results in conditions such as unstable angina and can lead to an acute MI. So what is the pathophysiology? A thorough understanding of coronary artery disease begins with a review of the basic mechanisms of coronary circulation. So how does circulation work? Coronary circulation consists of two main arteries, the right and left coronary arteries. These main arteries supply oxygenated blood and nutrients to the myocardial tissue. The coronary arteries originate at the aortic root distal to the aortic valve, and the aorta is the largest artery. The right coronary artery distributes blood to the right ventricle, right atrium, SA node, AV node, and the posterior heart. It's good to know the blood flow through the heart. It comes through the right atrium, right ventricle, goes up to the pulmonary arteries, brings blood back, comes back through the left atrium to the left ventricle. It's now oxygenated and it's pumped out to the heart. The left main coronary artery distributes blood to the left ventricle, left atrium, and the interventricular septum. It has two main bifurcations, the left anterior descending and circumflex arteries. The left anterior descending artery brings blood to the anterior interventricular septum and the left ventricle, including the apex of the heart. The second bifurcation is the circumflex branch, which distributes blood to the left atrium and the lateral wall of the left ventricle. Multiple factors regulate blood flow through the coronary arteries. The primary factor is aortic pressure. Other factors include heart rate. Most of the flow occurs during diastole when the muscle is relaxed. Diastole when the muscle is relaxed. Metabolic activity of the heart, blood vessel tone or constriction, and collateral circulation. The large coronary arteries do not have alternate communicating channels. However, smaller arteries are joined by collateral channels, also called collateral circulation. These are small blood vessels that develop to connect small coronary arteries. Should larger vessels become occluded, collateral channels provide alternative routes for blood, and so the heart will compensate, is what it's saying here. Coronary atherosclerosis is the most common cause of reduced coronary blood flow. You do need to know the term atherosclerosis and arteriosclerosis and what is the difference. Atherosclerosis is a progressive disease characterized by plaque formation. The plaque impacts the intimal and medial layers of large and mid-sized arteries. The etiology of atherosclerosis is unknown. Once started, the process causes lipoproteins and fibrous tissue to accumulate in the arterial wall. It is postulated that abnormal lipid metabolism and injury to or inflammation of endothelial cells lining the arteries appear to be key in its development. In the bloodstream, most lipids are transported while attached to proteins called apoproteins, forming assemblies known as lipoproteins. High levels of certain lipoproteins increase the risk of atherosclerosis. And I do want you for the next test to make sure that you understand and know the values of a low density lipoprotein versus a high density lipoprotein. So HDLs, LDLs, and cholesterol levels. You need to know the levels for the next test. So review those. For example, LDLs, which are high in cholesterol, carry cholesterol to peripheral tissues where some of it's released to be taken up and incorporated into cells for use in producing energy. Very low density lipoproteins, which are large molecules composed primarily of triglycerides and cholesterol, carry triglycerides to muscle and fat cells. When the triglycerides are released into the tissue, the remainder of the molecule becomes an LDL. Because the fats they carry can accumulate in arteries, both LDLs and very low VLDLs contribute to atherosclerosis. HDLs, in contrast, attract cholesterol, returning it from peripheral tissues to the liver. This, in turn, reduces the risk of atherosclerosis. The atherosclerotic process typically begins when accumulated fats and cholesterol cause damage to the arterial endothelium. Other potential mechanisms of vessel injury include hypertension, environmental toxins, infections, and inflammatory processes. Regardless of cause, after such vessel injury occurs, materials begin to collect in the intimal lining of the artery. First, atherogenic or atherosclerosis promoting lipoproteins gather and appear to bind with the extracellular portion of the vessel endothelium. WBCs, called macrophages, then migrate to the injured site as part of the inflammatory process. Next, contact with platelets, cholesterol, and other blood components stimulate smooth muscle cells and connective tissue with the vessel wall to proliferate abnormally. Although blood flow is not affected at this stage, the early atherosclerotic lesion appears as a yellowish fatty streak on the inner arterial lining. As time passes, the early lesion transforms into a fibrous plaque because of the enlargement of smooth muscle cells, proliferation of collagen fibers, and further accumulation of blood lipids. With lesion growth, protrusion into the arterial lumen occurs, fixing to the intimal wall. Further progression results in muscular medial layer invasion. Ultimately, the developing plaque can severely now or completely occlude the vessel, while also limiting the vessel's ability to dilate when increased oxygen demands occurs because it's blocked up. The final stage of the atherosclerotic process is the development of calcified lesions called atheromas, which consist of lipids, fibers, tissue, collagen, calcium, cellular debris, and capillaries. Atheromas can ulcerate or rupture, which triggers thrombosis, leading to rapid occlusion by the thrombosis or the clot may embolize to occlude a distal blood vessel. Plaque formation involved in atherosclerosis may be eccentric, located in a specific asymmetric region of the vessel wall, or concentric, involving the entire vessel circumference. Plaques tend to develop in locations where arteries bifurcate or curve or narrow. Bifurcate means they split into two different directions. It can also occur in the coronary arteries, especially the left and anterior descending artery, the renal arteries, the bifurcation of the carotid arteries, and the branching sections of the peripheral arteries. In addition to occluding blood flow, atherosclerosis weakens arterial walls and is a major cause of aneurysm in vessels such as the aortic and the iliac arteries. A lot of information here, but you see the picture here. You've got, all this plaque building up on the wall, and that's what it is. With atherosclerosis, again, it's a progressive disease characterized by plaque formation. Myocardial ischemia. This results when oxygen supply is inadequate to meet the metabolic needs. Blood supply to the cardiac tissue is reduced. The imbalance between myocardial blood supply and demand eventually causes temporary and reversible myocardial ischemia. Ischemia results when a tissue's oxygen supply is inadequate to meet its metabolic demands. The ability of cardiac tissue to satisfy its metabolic needs largely depends on two key factors: coronary perfusion and myocardial workload. Now, the more workload on the heart, the more oxygen it needs, so perfusion has to increase, and sometimes that can't happen because of the blockages. Coronary perfusion can be affected by several mechanisms. Myocardial workload may similarly be affected by heart rate, myocardial contractility, preload, and afterload. So the functions with inside of the heart, and here's a little picture that tells you what preload and afterload means. The blood's oxygen content and hematocrit levels are also contributing factors to myocardial ischemia. And so with the myocardial ischemia, again, you're having cardiac blood supply to the cardiac tissue is decreased. Okay, and just here's some pictures that you can see of that as well. Angina. So let's talk about the different kinds of angina. You have stable angina, Prinzmetal, unstable angina, and so you have three different ones listed here. Stable angina is the most common and predictable form. It results from a particular activity or stress that requires exertion, such as walking up a set of stairs. Stable angina is relieved by rest and nitrates. Like I was telling you, those nitroglycerin tablets, often people with angina carry nitroglycerin with them. Prinzmetal or variant angina is a typical angina that occurs unpredictably. It's unrelated to activity such as walking, and it often occurs at night. This angina arises from coronary artery spasms. While the mechanism that triggers the spasm is unknown, it is postulated to result from a hyperactive sympathetic nervous system response, impaired calcium flow within the myocardial muscle, or vasospasm due to reduced prostaglandins. Unstable angina is unpredictable, occurring at rest or with activity or stress. So it can occur at any time. Patients with unstable angina are at risk for acute MI, which is a myocardial infarction, a heart attack. So unstable angina, again, can be anytime, okay? So what is the cause? Before I get to this, I wanted to read this part to you. Not all myocardial ischemia produces angina. Many patients with ischemic heart disease experience what is known as asymptomatic or silent myocardial ischemia. Patients at risk for silent ischemia, and ischemia means reduced oxygen. The tissue is dying because it's starving of the oxygen. There's something's blocking it. Patients at risk for silent ischemia include those who are already affected by stable angina, unstable angina, post-infarction angina, or variant angina. Other risk factors include diabetes and a history of cardiac arrest, heart transplant, percutaneous coronary intervention, or cardiac bypass surgery. Silent ischemia often occurs with exercise and associated with a higher relative risk of serious events. So let's look, we're going to skip on page 241 of coronary syndrome and acute MI. Again, you will get that at a later time. The etiology, the underlying cause of atherosclerosis, CAD, and the resulting conditions are unknown. An individual's tendency to develop cardiovascular disease may be inherited, and lifestyle habits such as diet, heavy in fats, smoking, which causes vasoconstriction, and physical activity like decreased physical activity. And you have down on page 1242 the Framingham Heart Study. You can just read over that. I'm not going to ask you anything about that, okay? Risk factors. Although the exact cause of atherosclerosis has not yet been determined, certain risk factors are linked to the development of atherosclerotic plaques. And then the study is talking about, had some information about the research they did, that looking at potential causative factors and manifestations and protective measures with different populations. So let's look at the non-modifiable risk factors. These are the things that we cannot change. Age, we can't change. Sex, race, ethnicity, genetic, socioeconomic factors, and you can change that, and family history. And it gives you here, talking about ethnic groups, various studies indicate that African Americans, Mexican Americans, Native Americans, Alaska Natives, and some Asian Americans are elevated risks for this condition. So there are some ethnic populations that are higher risk, and it gives you a list there. Emerging risk factors. As researchers learn more about the possible mechanisms of CAD, the list of potential risk factors continues to grow. For example, studies demonstrate a link between elevated serum levels of homocysteine, which is an amino acid that is a homologue of cysteine, and CAD. Excuse me, I'm so sorry. Until menopause, females have lower homocysteine levels than males, which may partially explain premenopausal women's lower risk for CAD. Research also reveals that homocysteine levels are negatively correlated with serum folate and dietary folate levels. That is, increasing folate intake lowers homocysteine levels. Based on the evidence that aspirin and antiplatelet therapies reduce the risk for MI, clot-promoting factors have been recognized as another emerging risk factor for CAD. Inflammation has also been identified as a risk factor. Inflammatory processes may increase the development of atherosclerotic plaque, and they are implicated in plaque rupture. And that's what happened to my husband when he had a heart attack. He had plaque that broke off and ruptured inside the vessel, and it moved to another vessel and cut off the blood supply, so because his heart had compensated over time, and he didn't even know he had heart disease. Inflammation also promotes clot formation at the site of the ruptured plaque. However, because the exact role of the inflammatory and clot-promoting factors remains unclear, routine screenings for these factors is not currently recommended. Still, other evidence indicates that a group of risk factors, collectively known as metabolic syndrome, greatly elevates the likelihood of CAD. In fact, metabolic syndrome has emerged as a risk factor for premature CAD equal to cigarette smoking. Patients are said to have metabolic syndrome if they exhibit 3 or more of the following conditions. Large waistline, 40 inches or greater, 35 in females and 40 in males. High triglyceride levels, 150 or greater. Low HDL levels, less than 40 for males and 50 for females. And again, I do want you to know your LDLs and HDLs and cholesterol levels. Hypertension, 130/85 or greater, and elevated fasting blood sugar, 100 or greater. These conditions are themselves as the result of obesity, physical inactivity, and genetics. In addition to increasing the likelihood of CAD, metabolic syndrome elevates a person's risk of insulin resistance and type 2 diabetes, and that's kind of where I'm at in my life right now, dealing with type 2 diabetes. Risk factors unique to females, it talks about early menopause, and in trying to keep this from not being too lengthy, please make sure that you read this. Females going through menopause are at risk for CAD because changes in hormone levels cause the serum HDL levels to drop and the LDL levels to rise. So you want the HDLs to be higher and the LDLs to be lower. And I think I said that backwards. Don't quote me on that. I always get that backwards when I'm covering this. And I'll make sure and clarify that in class. Okay, so let's look at this again. A female's risk for CAD rises because changes in hormone levels cause serum HDL levels to drop and LDL levels to rise. The earlier a female enters menopause, the more likely she is to develop CAD. And again, I'm just looking. The increased risk is due to the tendency of oral contraceptives to raise LDL levels while lowering HDL levels. And so, again, where it's talking about the HDL levels drop, and so you want your high-density lipoproteins to be within normal range, which are a higher number, and you want your low-density lipoproteins to be low. And I'm going to clarify that. I always get that backwards. And so look over here on page 1245 while we're talking about this. And it's talking about hyperlipidemia, and I'm going to get to this. Make sure you know the numbers for this as well. And it gives us a chart to look at 1660. 16.6. So your total cholesterol, you want it to be less than 200. Low density lipoproteins, you want to be less than 100. And your triglycerides, you want them to be less than 150. So know those numbers, okay? And we'll cover that slide when I get there. And then it talks about oral contraceptives, making women more at risk too. Other clinical manifestations, You see, I'm sorry, I'm just looking at some stuff. Most common symptoms can be angina and MI, and differences between them are very subtle. Chest pain should be assessed by experienced healthcare professionals. So you want to make sure that you're ruling out, is this angina or a actual heart attack? So when you're looking at page 1244 and you're looking at these risk factors, make sure that you read over the diet. It talks about diets low in fruits, vegetables. I think I skipped the slide, okay, so I'm going to go back. Diet, fruits, vegetables, whole grains, and unsaturated fatty acids appear to promote CAD. A diet that are low in these things. So we want to increase these, okay? Diets high in these foods seem to be more protective. It talks about your activity level and how we need to exercise. It talks about obesity and our BMI. Make sure you read over that. It talks about cigarette smoking. We know that it's a vasoconstrictor. It talks about having hypertension and diabetes mellitus, and then hyperlipidemia. All of these are risk factors, okay? And again, I think I jumped the slide a little bit. Make sure that you look at table 1616 and you read over your levels here. LDLs are the primary carriers of cholesterol. High LDLs, listen to this. LDLs equal less desirable lipoproteins. So high LDLs promote atherosclerosis because LDL deposits cholesterol. So remember this, HDLs, highly desirable lipoproteins. So again, I had said it right. You want your LDLs low and your HDLs higher, okay? HDL levels of 60 or greater have a protective effect, whereas HDL levels below 40 for males and 50 for females put us at risk. And then LDLs and HDL levels, triglyceride levels are another important factor. Triglycerides are compounds of fatty acids bound to glycerol and used for fat storage. Recall that triglycerides are carried on the VLDL molecules, which transform into LDLs, and we said that a while ago, and it can lead to elevated triglyceride levels, which leads to CAD. Now I'm back on the right slide. So clinical manifestations, and again, you have to differentiate angina versus MI, okay? And you need to get them to the doctor. So what is angina? And this is the focus of our exemplar here. So angina, look at page 1245, table 16.17. And it gives you angina versus acute coronary syndrome versus acute MI. And I do want you to read over that, okay? You do need to know a little bit about MI as you are talking about artery disease. So let's look at angina. The cardinal manifestation of angina is chest pain. Common antecedents to the pain include physical activity, strong emotion, stress, eating a heavy meal, or exposure to cold. The classic sequence of angina is activity, pain, rest, relief. The descriptors used for angina pain include tightness, squeezing, heavy pressure, or a constricting sensation. These can begin beneath the sternum and radiate to the jaw and neck, and it can feel like a heart attack. It can radiate to the shoulder or the arm. Less characteristically, the pain may be felt in the jaw, epigastric region, or back. Characteristic patterns are more commonly seen in men. Females frequently present with atypical symptoms, including indigestion, nausea, vomiting, fatigue, and upper back pain. So you may think you have a virus. Anginal pain usually occurs in a crescendo-decrescendo pattern, increasing to a peak, then gradually decreasing, and typically lasts 2 to 5 minutes. It generally is relieved by rest, so that's angina. Other manifestations of angina include dyspnea, pallor, tachycardia, anxiety, and fear. So you have class 1, which is your mildest. Class 2 can develop rapidly. Class 3 significantly limits ordinary physical activity. And class 4, most severe, reflects angina with minimal exertion. So with minimal exertion or rest, you can still have angina. Our diagnostic test. Well, before we get the diagnostic test, look on page 1247, and here's your clinical manifestations and therapies: pain, increased heart rate, apprehension, and skin changes. Please read over that. It talks about what you will see as a nurse, and it gives you those the clinical manifestations and then the clinical therapies. Again, using nitrates, using aspirin, that administration of analgesics, vasoconstricting medication to improve blood pressure. Please read over that. Collaboration. Care of patients with CAD focuses on managing risk factors to slow the atherosclerotic process and maintain myocardial perfusion. Until manifestations of chronic or acute ischemia are experienced, the diagnosis is often presumptive based on the patient's history and presence of risk factors. Specific therapeutic measures may be initiated once patients experience angina or acute MI. Management of stable angina focuses on maintaining coronary blood flow. You got to have the blood flow because, the person could die. Okay, and so we need to, if the angina doesn't go away, then it may not be angina. Look at your diagnostic test. You have C-reactive protein, and it can be elevated. Anchorbrachial blood pressure index. Your exercise electrocardiography testing, electron beam, myocardial perfusion, cardiac markers, and some of these cardiac markers are CK, which is creatinine phosphokinase, CKMB, and troponin levels. And they'll do a troponin level to rule out if it's a heart attack or not. Your troponin level can remain elevated for 5 to 9 days or 7 to 10 days after an MI. And look in the chart on page 1249, and it gives you the cardiac troponin levels less than 0.2 and 0.1 to 0.5. And so if they're any greater than 0.5, then you may have some heart damage to the muscle. When my husband had his heart attack, his troponin level was 76. So he had significant injury to that heart muscle. Please read over these again and try not to keep this too lengthy, but these are the labs that they look at. Under diagnostic testing, they'll also look at your lipid profile, again, HDLs, LDLs, your triglycerides, and you got a table for that, okay? And I'm just looking to see, again, people with elevated cholesterol are at very high risk for coronary artery disease. Again, back to other diagnostic testing, electrocardiography, and they will do this to look at signs if they've actually had a heart attack, or they're trying to rule out, is this a heart attack? And if it is, you'll see changes on the cardiac monitor in the Q wave and the T wave and the ST segment, but you all will get that when you talk about MI in 211. Again, here's all of the diagnostic tests that they do. Please know your again, LDLs, HDLs, and I want you to know the troponin level too, okay? So know that range, 0.1 to 0.5. Anything greater than 0.5 indicates some cardiac muscle damage, okay? Stopping smoking, it talks about smoking cessation. Make sure you read through that. It talks about the diet, a low saturated diet, meats that are low in fat, vegetables, fruits. We don't want high fat foods. And you have a table 16.9, and it gives you some recommendations like whole grains, nuts, legumes, fruits, vegetables, and legumes or beans is a type of beans. Please read through this because I do have some dietary questions on what kind of diet would be appropriate for someone that has coronary artery disease or at risk for angina and things like that. Okay, so it talks about diet, moderate alcohol intake. Again, we know we need to maintain our weight. We need to exercise at least for 30 minutes a day, if nothing but walking, and it's just better than sitting around doing nothing. Keeping your diabetes under control, keeping your blood pressure less than 130/80, decreasing your sodium intake, reduce sodium, increase calcium because calcium helps the heart muscle, increase exercise, and take your medicines. And look on page 1251. Here are the most common statin drugs for cholesterol. Anytime you see a drug that has statin on the end of it, automatically think that it's a cholesterol medicine. And it gives you nursing considerations like report elevated liver enzymes, assess for muscle pain and tenderness, monitor the CK levels. So make sure that you read over that. And then these people need to take these drugs on a routine basis. So medication 16.2, you got your bile acid sequestrants, Questran, Welchol, those are still in use, your niacins, and then your fibric acid agents, Tricor, Lopid, those are still used out in practice a lot. Again, conserving your, making sure your diabetes is in control. And here are some of the medications. Now, again, aspirins, we use aspirin to help with the chest pain and help prevent, it's an antiplatelet medication. So when you look on page 1253, it talks about drugs to treat angina. So I really want you to pay a close attention to that. Multiple drug categories are indicated for both acute treatment and long-term management. And some of these are your nitrates, beta-adrenergic blockers, and calcium channel blockers. And it lists under the nitrates, and the nitrates dilate the vessels so you can get some more blood flow in there. It can cause rapid drop in blood pressure, and the patient may have a bounding headache. And so you need to pay attention to that. Please read through this. A patient that's taking nitrates, you need to make sure that they're well protected from falling. Just moving from a sitting to a standing position can lower their blood pressure. ACE inhibitors, these are angiotensin converting. We know the inhibitor prevents the angiotensin 1 from converting to angiotensin 2, and angiotensin 2 causes vasoconstriction. So stuff as captopril, lisinopril, all your pril drugs are your ACE inhibitors. Beta-adrenergic blockers, this is your atenolol, metoprolol, your Lopressors, your Corguard, propranolol, which is Inderol. With beta-adrenergic blockers can trigger severe bronchospasms. A lot of people that take these cough a lot. They have a all the time. You just hear them do that all the time with this drug. They are contraindicated for patients with severe obstructive pulmonary disease like asthma or COPD. Beta blockers should not be used in patients with significant bradycardia. And all of these drugs, you need to check their pulse and their blood pressure before you give these, and check their electrolytes as well. Beta-adrenergic blockers may cause coronary artery spasm and worsen Prinzmetal angina. And then you have your calcium channel blockers. and this reduces myocardial contractility and heart rate and increases coronary vasodilation, reducing both oxygen demand and increasing oxygen supply. And so some of the medications that you use with the calcium channel blockers are often used to treat dysrhythmias, heart failure, and hypertension. So when we talk about heart failure, you're going to see this again. You have your Norvasc, which is amlodipine, diltiazem, which is cardizem, nicardipine, which is cardine, nifedipine, which is Procardia. And Procardia comes in a capsule, and you can, in an emergency, you can puncture the end of it and squirt it under the patient's tongue. These drugs are high-powered drugs. You need to make sure that you are assessing the patient before you give these medications. And then just to mention briefly, for the patient with a heart attack, we know the drug of choice is morphine sulfate, and so we give it IV, and you also give thrombolytic agents such as heparin. And with heparin, we check the APTT, and with Lovenox, we check the PT and INR, or Coumadin and Warfarin's PT and INR. But if you're on heparin, you check the APTT. And so there's different medications for the MI, okay? Antiplatelet drugs are listed on page 1255. Of course, aspirin is number 1, okay? And we need to monitor our platelet levels, okay? And then now we're looking at interventions to treat CAD. And these are listed here for you. Make sure you read over this slide. Oxygen 2 to 5 liters, bed rest. They don't need to be anything aggressive. Low fat, low cholesterol diet. Liquid diet maybe for the first to 12 hours. And limit caffeine, because caffeine increases your heart rate as well. And then with the heart, if you're having a heart attack, you may have to have a cabbage. I'm not going to ask anything about that. You'll get that in the MI. And all of this other interventions, I'm not going to ask you anything about these devices. Lifespan considerations, make sure you read that on your own, okay? Nursing process, your observation and patient interview, your nursing diagnoses. Please make sure you read over these. I do have some nursing diagnoses on the test about the concept of perfusion, because you have multiple exemplars we're covering for perfusion. Because I'm at almost 45 minutes now, you can read the nursing process on your own. We've already talked a lot about the diet and what kind of diet. Make sure you know what kind of diet we're looking at, because I will have some questions. And there's your nursing diagnoses, okay, your goals. There's your nutrition, and how do we promote a healthy lifestyle. We need to get out and exercise, 30 minutes, walk, or if you can do more than that, it increases our breathing and our stamina and helps get circulation going. Managing acute pain. They may need oxygen at 2 to 5 liters. They may need IV nitroglycerin to relieve chest pain, but again, make sure that your blood pressure is in normal range and your heart rate's in normal range. Monitor tissue perfusion. Look at the vital signs, heart rate, blood pressure. Look at the skin color. Look at breath sounds. Look at the EKG monitor. Make sure their pulse ox is good. Make sure the head of the bed is elevated. Their oxygen is on. Look at their labs. Promote effective coping, because people are very scared when they have heart problems, and you want to be able to work with them on that. Effective cardiac tissue perfusion. One big thing about cardiac patients is making sure that they take their medicines and try to cut their sodium intake. Coach patients to use sublingual nitroglycerin before engaging in activities that precipitate angina. This is on page 1262. Again, try not to keep this too long. Please make sure you read through the interventions, and we will go over these in class as well.